Okay, welcome everyone. It says I'm live. It took a minute there. I see some folks are already here. If you want to leave a quick comment or chat, let me know that you can hear and see me okay. And I will also get us started off. So, for today, we're talking about beyond checklists. Really, what can you do to make your diagnostic process ethical and compassionate and truly helpful for clients? That was interesting in some of the research that I found, the actual client perspective of the diagnostic process. I think that's a key piece that sometimes gets left out because we're so focused on being able to document it and make sure that it meets certain standards, mostly with insurance and payment. But there are a lot of other pieces that come into diagnosing. So we've already got one chat here. If you have questions or thoughts as we go along, feel free to put them in the chat, and then also you can email them. So if you have any questions or concerns that maybe you don't feel comfortable putting in the chat or just can't figure it out for any reason, I do have my email pulled up so we can I'll keep an eye on both of those. You got multiple ways to send over questions and concerns. I'm going to start off with our first objective, talking about key ethical standards and legal considerations that you can apply when you're working on diagnostic assessment in your mental health practice. And first and foremost, I think the good question to ask is, can you legally diagnose? Because truly, as I look through this, each state and each profession within each state and their different boards really outline the legal ability to diagnose very differently. So, this is going to be in your statutes or administrative codes for your state and your profession in that state. As an example, in North Carolina, we actually have separate boards for each of our different professions. So, for licensed clinical mental health counselors, for social workers, for marriage and family therapists, all of those are different boards with different statutes and different administrative codes. Some of the states do have it more combined. So you can see maybe all on one page where you might fall in licensure or certification, as well as what your ability to diagnose is. So with North Carolina, because I know that best, that's where I'm from, where I'm licensed. For our licensed clinical mental health counselors, we have an associate level and then we have an independent level and we have a supervisor level. But I really want to look at the associate level and the independent level of the same licensure type and note that both of those can legally diagnose based upon our statutes and administrative codes. Some states, the associate level, so meaning you are still under supervision, you cannot diagnose. And that is in some of the states like Nebraska, the licensed mental health practitioner. It's a mouthful. Why are they all a mouthful? Licensed mental health practitioner does not include the ability to diagnose a major mental illness or disorder, except in consultation with a fully licensed and independent. That is their version. So, licensed independent mental health practitioner, qualified physician, or licensed clinical psychologist. So there is the option there to diagnose, but it has to be done within supervision or within consultation with one of those three types of professionals. At the independent level, they can diagnose, they can treat major mental illness and disorders without any sort of oversight, like supervision or consultation. I'm sure this is different in many states as well. The difference between like a physician's assistant or sometimes the different nursing types, as well as like a medical doctor. And I know that for at least in our state, physician's assistants need that additional supervision or consultation to be able to do certain things, like maybe diagnose or prescribe medication, similar with some nursing types here in my state. So that's kind of how I'm viewing this is for some states, not all, you may need some additional supervision or consultation at that supervised level. that associate or intern level, sometimes it's called. A different state, looking at Maine, where these were all combined on one page. They all had very similar names. So if you're from Maine, how did you decide what to apply to? Because they have like XL and XC next to them. It was very interesting to see the different licensure types and then the different levels within each licensure type. So they've got the conditional clinical professional counselor, and then also the independent level of that same. They can both diagnose and treat mental health disorders. Differently, though, a conditional professional counselor cannot diagnose or treat mental health disorders, whereas the professional counselor also cannot diagnose or treat mental health disorders. So, regardless if it's the conditional or the fully independent, if it's a professional counselor, neither of those can diagnose. You have to be the professional, the next level clinical professional. So I don't know. It was very confusing going through that, but it's good to know that there are different types within each state, and some of them, if you're at a level of needing supervision, then you cannot diagnose. Some you can with supervision or consultation. And then there are others, whether you are at the provisional level or not, the independent level, regardless, you cannot diagnose. So, really knowing what is required of each licensure type or certification level and what you have. Within Maine as well, marriage and family therapists, both conditional and independent, they can both diagnose and treat mental health disorders. So I didn't dive too much into like the education requirements of each of these or the clinical requirements, but it is good to know that what you have, what you hold, your license type may or may not have the ability to diagnose, and you may need supervision or consultation. I'm also thinking in California at the intern level, my understanding is you cannot diagnose. So, something else to keep in mind. Some states use intern, some states use associate level, and those are essentially the provisional level where they're not independent. So just know the difference, know what you have, read your statutes, read your administrative codes, and make sure that you legally can do a diagnosis. Um, some don't really note the difference between the provisional and the independent license type or certification types, and rather, they kind of have a blanket statement that puts the requirement on the provider to determine whether or not it would be appropriate for them to be able to diagnose clients. So they'll say something along the lines of a provider needing to have, quote, additional training, certification, clinical experience to diagnose. So as a professional, you're making this determination. Do you have the training, the experience needed for this? And I don't think that there's a direct answer to that. It may not be until something is legally challenged to actually determine whether an individual provider did have what they needed as far as education and whatnot to make a diagnosis. There was a state or two that I saw. um, I think it was social workers were required to consult with a physical health provider as a part of the diagnostic process. So this the way it was worded when I read it was basically either you need to collaborate with the current physical health providers of the client, or you need to get the client connected with physical health providers who you then continue to collaborate with. So again, read the statutes, the administrative codes that apply to you, your license, your board, your certification, whatever it is. Talk to your supervisor, get consultation to really determine whether or not you have the legal capacity to make a diagnosis. The other part of this, in addition to ethics, is or in addition to the law and the legal piece, is our ethics, which sometimes are more overarching than some of the state level statutes and administrative codes can be. I've talked about this before, so if you've already heard it, sorry to dive back into it, I really like the American Counseling Association's code of ethics related to diagnosis. They have an entire part, it's E5, diagnosis of mental disorder. And then they have considerations under that. I think it's spelled out very clearly what they expect of counselors who fall under this code of ethics, which per my license type and my state, actually, this is the code of ethics that they have adopted. So, E5A is about proper diagnosis, meaning we use assessment techniques, including any interviews that we might do, that we are carefully selecting these and using them appropriately. I will talk later some resources about how you can do an assessment for a diagnosis. There are some books out there that you can use. Of course, the DSM is kind of our go to, right? You can take the DSM and create a checklist of sorts for each diagnosis. But there are books that help to break it down and make it a little bit simpler and easier to use. If you are using questionnaires or inventories, how did you determine that those were appropriate? And how are you making sure that you're using them accurately in the way that they were originally intended? The personal interview piece, I think, is what most of us think about, where we are just asking clients questions and gathering background information, sometimes information not just from the client, but also from other people that are in their lives, maybe their parents, maybe their spouses. Personal interviews, are we using that appropriately as well? Which there are some structured interviews that help with this, and I'll mention those in some of the resources later on. It's not something that you have to create from scratch. This is something that you can use to guide you in that interview process. The next one is E5B, cultural sensitivity. And essentially, the ACA is saying we need to recognize what role culture plays in diagnosis. How does this affect how a client's problems are defined, how they're experienced, maybe how they express that to us? How does culture play a role, but also socioeconomic considerations when diagnosing? That's all under this cultural sensitivity umbrella here, related specifically to diagnosis. So, how are we making sure that it is culturally sensitive, whether it's the tools that we're using, whether it's the interview questions that we're using, how we are incorporating their background into that diagnostic assessment process? E5C talks about the historical and social prejudices in the diagnosis of pathology. For us to, and this may be a throwback for some of you who are further out of school, think about the textbooks and the history of diagnosis and any of the social prejudices that come up, specifically the ACA notes regarding misdiagnosis and pathologizing certain individuals and groups. The DSM doesn't do a great job of this, although it does have some sections, both kind of standalone in the DSM as well as after each of the diagnostic criteria, talking about some of the implications for each diagnosis based on the history, potential ways that it can present, how it might be misdiagnosed, and all of those things, in addition to some of the more recent research, should be a part of our consideration when looking at a diagnostic assessment with the individual client in front of us. The ACA also tells us as counselors to not only be aware of these biases for ourselves, also to help others if they are exhibiting any biases. I think this often is pretty like straightforward with supervision or consultation. We're already working with someone. But what if you get a report or get some documentation on a client and some of the diagnoses or some of the diagnostic process was a part of this like prejudice? or pathologizing. Would you maybe reach out to that person and educate them on the biases here, or at the very least, find out what happened during that assessment and during that diagnostic process? How did they come to this diagnosis, especially if you yourself are considering it as a misdiagnosis? Because these often do end up on clients' healthcare records. I always want to say like permanent record, like when we were in school, they said if you get in trouble, it's going to be on your permanent record, and it kind of feels like that. These are our medical histories, and with so many of our electronic healthcare records being connected in different ways, it really does end up on our record, and it hangs around. So this is another reason why this prejudice, issues with pathologizing individuals or certain groups, is a big problem. And then my favorite one, if you've been around, you know this already, E5D, refraining from diagnosis. The ACA specifically puts in their code of ethics that we as counselors would refrain from making or reporting, that comes back to being on that healthcare record, reporting a diagnosis if it would harm the client or others. Of course, that would be an ethical dilemma that you would have to do some sort of ethical decision making process through, determining if a diagnosis would harm the client or others, and whether you should make the diagnosis or at the very least refrain from reporting it. So, I don't have a straightforward answer on that today, like how you would know the difference. I do recommend that you use some sort of ethical decision making process to come to that determination. And I'll talk about that more in the last of our pieces today around documentation. The new Social Worker magazine had an article about the DSM, the ethics of diagnosis, and they emphasize the different parts of the code of ethics related to this: respect, empowerment, professional competence, and duty of care. I think that that is easily mapped onto some of the areas of the ACA code of ethics that we just talked about, as well as the legal responsibility that we have as professionals when making a diagnosis. And then the American Association for Marriage and Family Therapy do speak to competence in diagnosis and holds many of the same tenets as the ACA and the National Association for Social Work Code of Ethics. Competence brings me right back to that piece in some of the statutes that basically says, well, yeah, so your license or your certification gives you the right to be able to diagnose, but do you have the competence, and how do you determine that? And that's exactly what they're talking about here for marriage and family therapists. Maybe your license does give you the right to diagnose, and do you have the competence to do that? And that, of course, is a multi-layered question as far as do you have the competence with education, training, and whatnot, but also based upon different diagnoses. And I won't go too in depth into that. I know that could be a whole another conversation for another day. But how much experience do you have in particular diagnoses, whether working with clients who have those diagnoses or in actually making and assessing for those diagnoses? Okay. So I'm talking about legal and ethical pieces for about 15, 20 minutes now. I don't see any comments, questions. Feel free to put them in if you have any. Send them my way. I'll be sure whether I respond to them today or if I, catch them after, I'll try to respond, especially if you're looking for specific resources. I'll move into talking about how to collaboratively and transparently work with clients around diagnosis. And this includes talking about risks, benefits, and alternatives, which comes right back to what I talked about with the ACA Code of Ethics. There was some research done, and it looks like these researchers have done various pieces of looking into clinicians' perspectives of the diagnostic process as well as clients' perspective of diagnosis. So this is Hackman et al. From 2019. And like I said, they pull in some of the research, not only from this, but also from other articles they have done or other work that they have done. And they really talked about a collaborative process would include these three steps. One, assessing and deciding the diagnosis. Two, communicating and agreeing on the diagnosis. And three, clinically applying and using the diagnosis. And I will talk about each of the stages from the clinician's perspective and the client's perspective. And after each one, I'll go over some key takeaways for how to make your diagnostic process more collaborative and transparent. The researchers acknowledge, and I also want to acknowledge that there are many parts of the process that could be undermined in certain environments or situations. So, if there is an emergency and a diagnosis has to be made very quickly, then you might not be able to go through all three of these steps. Also, settings where you're not really integrating services or resources as much, then also that may not lend to all three of these steps. As someone who does standalone assessments as well as ongoing therapy, I have been able, in both of those instances, been able to use all three of these steps. And I'm always trying to improve it. So I will throw out today some of the opinions and things that I do as a part of these three steps. And if you have any that you would like to put in the chat and share with others, please do. But I will kind of note some of the ways that I apply this, or if I don't agree with the researchers, I'll give you that as well. So, stage one, assessing and deciding the diagnosis. There are some factors that clinicians should take into consideration, and they pose these as questions. The first one is, what is driving the reason for a diagnosis? Is this about a client seeking treatment, support, or care? And maybe the client sees the clinician as a gatekeeper to services. And honestly, I think the researchers kind of say this. I don't know that they mean to. It's hard to read through text. They say it kind of flippantly, like, oh, we're just seen as a gatekeeper. When in reality, we are. Often a diagnosis is required for access to some services. And when we talk about the power differential, I think that that's really important to keep in mind. We do play a role as a gatekeeper. So it makes sense that clinicians would see us that way and they would come to us so that they can seek those services, treatment, care, etc. Clinicians feel responsible for providing services and are subject to multiple systemic, professional, and legal pressures. I've talked a little bit about this, but it can depend upon where you're at, what setting you're in, as far as what pressures are on you. Are you in your own private practice and your private pay? So maybe diagnosis doesn't matter as much. Or are you in community health and folks are using maybe Medicare or Medicaid and a diagnosis is required? Then what pressure do you feel to provide a diagnosis for that reason? So those are just two examples, but there are many different systems and environments that we are in. And if we're not kind of at the top of that decision making tree, then we may have people who are telling us we have to do one thing or another. So, of course, all of this is going to explicitly and implicitly influence the way that we are motivated to make a diagnosis, the reasoning behind our diagnosis, and expectations for what might happen with a diagnosis. Number two, what expertise do you as a clinician and the client bring to the process? Often our expertise is focused on as clinicians, what training do we have? What education do we have? What oversight do we have? And we can forget that the client is also bringing a lot of expertise into this. So we might be an expert, we might have clinical experience, we might have that medical authority to make a diagnosis. The client though is an expert in their history, in their mental health, in their past service use and treatment as well, and their symptoms. Clients often come to us with some sort of mental health literacy. I think it's rare at this point for me for folks to come and not have any real insight into the DSM, what it is, how it's used, even some of the diagnoses and potential criteria. Uh, and on the other hand, us as clinicians, we often have lived experience with mental illness, or if not ourselves, we know someone, not just our clients, but someone who's like personally related to us who has mental illness. So we're both coming in with different levels of experience and expertise, and it doesn't just fall to one side or the other. Being able to draw on and integrate both of our expertise, being able to look at the learning experience that we have together, our experience over time. This is going to make it collaborative and it's going to make it transparent and they say reciprocal. As much as we're putting into this, hopefully clients are getting out of it and vice versa. Number three, are there issues related to power and control? And this is another area where I feel like and maybe they didn't feel like they had enough time or space to do it. I don't think they went as in depth into this as I would have. My opinion is like there is an inherent power imbalance, period. We ultimately hold the power to make a diagnosis or not. So, whether clients agree with it or not, we still at the end of the day can make a diagnosis. I'm not saying that's right. Like if a client doesn't agree with it or has an issue with some aspect of how we made the diagnosis, at the end of the day, we still can. We hold that power. And of course, that ends up in their health history and affects their subsequent care and treatment. So, the way the researchers noted it was that clinicians have perceived status and authority, but the reality is we have actual status and authority. Our education, our license, our certification, and that legal power to diagnose is there, and you can't deny that. They did note that the dominance of the quote biomedical and legal model has been associated with disempowerment in the diagnostic process. So rather than focusing on the client and what the diagnosis is going to do for them, how is it going to help them? If we are just focused on checklists going through, then we're probably not meeting them in a very empowered space. They don't feel like they have much control over that or much ability to provide insight. And the fourth question here is the client aware of all of the information that is used for the assessment? Um, it has been that for some medical providers and mental health providers included, that the client's expertise in their own physiological, emotional, psychological, social experience, all of that has maybe been disregarded because we're seeing it in a different light or we're seeing different patterns than they are. We might not be taking into consideration their explanations for how or why things have happened. And an example of this that kind of pops into mind is if we're talking about trauma, and maybe two people can go through very similar traumatic experience. One indicates that for them it was traumatic and for the other it wasn't. So maybe on like a societal level we can agree that hey, that would be a traumatic experience, and for one they're saying it is and one they're saying it isn't, or vice versa. Maybe there's something that happened that many people would look at and say like, "Oh, that's not traumatic." That, anyone be able to bounce back from that. But we've got clients saying that it was traumatic. So, how much are we listening to clients and not just assuming or assigning things to their experience? It can lead to limited exploration of their history, of their lived and felt experience, which then decreases the information we have. And we're maybe not able to make a full picture of what this person's life has been like up until now, or what might be contributing to their current symptoms or maybe past symptoms. So if it's collaborative, it's going to naturally, explicitly value the information that clients are bringing alongside what we have as far as our professional view and clinical experience. And they often note in this article that having a multidisciplinary team can be very helpful. So, having several people who are supporting the client involved to give different perspectives and for everyone to work together with the client in that diagnostic process. I know that that's not always possible, but it could be really helpful for some clients. On the client side, some questions they might be asking themselves. One, is the decision to diagnose driven by my need? So, is this provider making a diagnosis because it's going to help me? And if they feel like it is driven by their need, meaning they want a diagnosis to gain access to care, to gain access to treatment, different types of supports like accommodations, for example, as opposed to just because the provider needs to, it's a part of the first session, it's just what we do. Uh, if they feel like it's really driven by their needs, then it can contribute to the process being perceived as more useful and informative. I can imagine clients would just kind of check out if it feels like it's just another thing that we have to do. It's just a part of what we as mental health providers do in the first session or the first few times that we meet. That it's only done for a billing reason. And yes, many of us as clinicians feel the same way. Like, why do we have to have a diagnosis for billing? If we talk through that with clients to let them know that if they want to bill insurance, then we have to do a diagnosis. At the end of the day, it's a part of what they need and their reason for coming to services. So, how can we make sure that it's really centered around what the client needs and how it helps them gain access? Where we might see as clinicians legal or clinical demands, maybe you work for a practice or supervisor who does require you to make a diagnosis, um, then that's going to be difficult to involve the client in all of the decision making process. But we can bring them in and let them know what's going on with our diagnostic process, make sure that they are informed. There's gonna be some instances where we just can't. Those acute situations, emergencies that I noted, um, but really think through at what point can we bring a client in to the decision-making process? If it is an emergency, once things have calmed down, are we able to talk to the client more so about that? Can we work to challenge any assumptions that might be made that are undermining the client's ability to get care and to receive the best care for them? So that might mean advocating with or for the client about their needs and how this diagnosis maybe is hurting them, if that is the case, or how it can be helpful to them. So we're not undermining their agency. Make sure that you're using really careful clinical judgment in these instances. Sometimes we can get wrapped up, especially in emergencies and just doing the thing, going through the steps. And sometimes we need to step back. And maybe that means asking for help. A supervisor, a colleague, getting consultation, even if it's a different in that team, maybe we have other providers who aren't mental health providers, but we can still get their input as well. And we'll talk more about this in documentation, but what is the rationale for the diagnosis? What is the rationale if we don't include the client in making the diagnosis? Really making sure that this is not only talked about, but documented and written down. Any decision that we make, especially those without the client present. Why did we do that without the client being involved? The client might wonder, is my expertise in terms of my history and experience valued? In the research where the diagnostic process has not been collaborative, clients will often say that they feel that their expertise is undervalued, that again, that imbalance of power shows up, and they have learned helplessness and passivity, meaning they're not as involved in their treatment, in the process, in the planning, being able to set the goals and so forth. They kind of check out of the process. Clinicians who don't take on the client subjective accounts um, are seen as wanting clients to just be seen but not heard. So they're viewed as, okay, just show up and I'll do the important thing. I'll make sure that I go through the process and get a diagnosis. It doesn't really matter what you think or what you want to contribute to this. I've got my own checklist and I'm going to do this by myself. Um, Clients don't feel like they are actually being heard. Also, and this can be kind of scary for some of us, if you're making a diagnosis and you're sharing that with the client, that does leave room for them to question the diagnosis. If it's not collaborative, if we're not telling them about the process, we're not telling them even what the diagnosis is, then that can look like we're the ones who know everything and the client doesn't know anything. So we've kept them out of that process and they don't need to know anything. Was that like in um the shows with like the FBI or the CIA, and it's like it's a need to know basis. And so we're basically telling clients like, yeah, you don't really need to know this, which is not true from my opinion. The client might ask if they have agency and control in the process. That imbalance of power can really undermine the client's confidence in themselves and the confidence in participating in the treatment decisions. So, if you've gone through a diagnostic process, not brought them into it, not told them anything, and then you start asking them about goals for therapy, that doesn't quite add up, right? Like, if we're not including them from the very beginning. There is the potential for clients to feel like they need to just show up as the good client. They need to be passive and compliant and just do whatever it is to make us as clinicians happy, which I don't think at all is very helpful. And I think the research would back that up as well. It's not helpful for clinicians, it's not helpful for the treatment. And at the end of the day, it's really not helpful for clients. And I think would go against most of our code of ethics. The client might ask, can I access or understand the information used for the assessment? So it has been found in research that clients want to know what we're thinking. They want to know about the time frame of the diagnostic process. They want time for questions. They want time to think through what the diagnosis is and what it means, especially for them, but also for the treatment process. They want to know more. I have described our field as mental health professionals sometimes as smoke and mirrors, or we're kind of like the man behind the curtain, like we just have the thing happen, but we don't really tell anyone why or what's going on, right? And that does everyone, again, a really big disservice. So I hope I am encouraging you to step out of that and to collaborate with clients and talk to them more about the process. Be open with them about what you're thinking and how you arrive to that. Um, don't make it that smoke and mirror situation. There are a lot of sources of information that we can use as clinicians in the diagnostic process. And it could be that some of these are inaccessible or difficult for clients to understand, which is then going to decrease their role and agency in the diagnostic process if they can't understand where we're getting the information from or why we're using the information or what the information is. So, some of this could include members of their mental health team, if there are others, if many of us here are maybe mental health, like licensed clinical mental health counselors, and we also have maybe a social worker who's on the team, or we have a physician's assistant or a psychiatrist. who all is involved in that team addressing their mental health, we might be taking this information in, and the client may not know that. They may not know that we have those records, those documents, that paperwork from those other providers. So, how can we make sure that they do know where we're getting some of the information? It could be from medical records from other providers that they've met with that we've never talked to, but we can see it in the history in the chart. Do they know that we have access to that? Do they know what we're reading? And do they agree with what's in there? All of those are really good questions. Do they understand what diagnostic manual or system we're using? So, if we're using the DSM, what do they know about the DSM? I mentioned earlier that many clients who come to me seem to know a lot about the DSM. Maybe they've researched it, found information on the DSM, maybe they've done their own questionnaires online related to the DSM. So they tend to know more, but we can't make that assumption that everyone knows what the DSM is or how it's used. And that includes the language in the DSM. So the symptoms that are listed in there, some of the technical or medicalized language that is used as a part of diagnosing, they may not understand that. Honestly, sometimes I find it really difficult to understand. And I'm like, wait, what does that? Let me let me search that. What does that phrase mean? Um, so making sure that we are decoding that, that we are sharing with them like a language that we're using, making sure that what we're saying as far as our medicalized language matches up with their lived experience. And one of the examples is euthymic. Might be something that you often find on like your observations or your mental status exam. Like, what sort of affect do they have? What sort of emotions are they expressing? Euthymic basically means like stable mood. I didn't know that before I got into the field and started doing some research around it, and I doubt most of the clients that I meet with know what that means either, unless that's just a part of what they see every day, maybe their research or whatever. That's not a word that we kind of throw around in our everyday language. So that might also mean your documentation, making sure that it's easy to understand. If you have euthymic in your paperwork, maybe just add parentheses that says stable mood next to it. So anyone reading that would understand what you meant as well. So, what are some takeaways from this first stage? Consider your reasons for the diagnostic process and the client's reason for the diagnostic process. Be sure to discuss with them what the patient has thought about the diagnostic process, what questions they have, what reasons they have. Really consider who or what, I guess is fair, what is driving this reason for a diagnosis? Is it from us solely as clinicians? Is it from our practice or from insurance or whatever it is? Or is it from at the core the client's need? That's the question. Discuss whether the client would find a diagnosis helpful. So be sure to explain and consider that it might help them make sense of their mental health and what they have been experiencing. It may offer a shared language for the client to use with friends, family, others, maybe at work. They have a shared language now. What about decision making in terms of treatment? How would anxiety versus depression change the treatment process? And what if both are present? How does that change the treatment plan? Um, Thinking about prognosis and recovery, talking about what that might look like typically for that particular diagnosis. We know that it's different for everyone, but there are some kind of common understandings around how different diagnoses progress and whether or not recovery might be possible or what it would look like, honestly. What does in remission look like? Talking to them about that. Make sure that you have offered the client the option to go through the diagnostic process. uh, basically explaining to them why a diagnosis might be needed and what the diagnostic process would be like. Make sure that you're not reducing the diagnostic process to something really simple. Make sure they understand what it means to have a diagnosis. Um, that not going through the diagnostic process, what would the pros and cons of that be as well? How might a diagnosis affect their sense of self and identity? It could be negative, it could be positive. It could be stigmatizing, but it could also help to alleviate stigma. So there are a lot of things that go into a diagnostic process and the results. Make sure the client knows both sides of that. So take time to weigh the pros and cons with the client. And really, if you leave with nothing else today, a collaborative diagnostic process values the client's expertise and their lived experience. Make sure that appointments are long enough so that you can talk about the diagnostic process. They can add any discussion they need. They can ask additional questions. You have time for active listening. You're not just rushing through things, that you make explicit links between their lived experience and your diagnostic reasoning, being able to show them, hey, when you describe this experience, this is how it showed up in the DSM language. Invite them in to question you and challenge your reasoning. I know that can feel really uncomfortable too, but if we don't let them know that they can do that, they may not understand that they can. Again, we are seen as this expert. We have this overarching power and authority, and they shouldn't be challenging that. But that's just not true. In a collaborative process, you would invite them in to question and challenge what we've discussed. Share and decode the language that you use as far as the diagnostic criteria. Specifically, I'm thinking here from the DSM. If you are showing them, hey, these are the diagnostic criteria that you met, write out like what is the criteria from the DSM, let them see that, and also tell them how it relates back to them individually. And then talk to them about having an informed decision around diagnosis and what of maybe you're looking at several different diagnoses or just one, but how does this resonate with their lived experience? Stay aware of the power imbalances and dynamics that I talked about. Make sure that when you are acknowledging it and discussing it with the client, that you're being really sensitive to how this comes across, while also inviting them in to challenge some of the power imbalance. Let them know that sometimes the process can take a little while. There can be some uncertainty, that you might be waiting to track mood over time. So I think sometimes I'm just thinking about the irony here, that some of us as clinicians are saying like, "Oh, we got to get this done in one session." And maybe clients are also assuming, "Oh, it needs to get done in one session," when in reality, maybe it should take multiple sessions, whether spread out over multiple days or weeks or even months if you're trying to be super accurate. Okay, I'll keep going. I'm looking at stage 2 here. Communicating and agreeing on the diagnosis. There are some factors for both clinicians and clients. And this was kind of a good segue for clinicians. Think about the time taken to diagnose. Some clients have reported relief at getting a diagnosis after what they called a long delay. So, being open and transparent about the process so that they can understand any reasons for the delay. Let them know that we are trying to find a diagnosis that would be useful and that we can both agree on, that matches their actual experience. And honestly, that a diagnosis isn't always like a static label, that it doesn't just, okay, you diagnose depression and it never ever changes. We've got many different specifiers, there's different levels of severity, there's a lot of flexibility around diagnoses that can change over time. And letting clients know that as well. It's not just about that first session or first diagnosis, that over time this is going to change and evolve. Thinking about multiple diagnoses, if clients receive several potential diagnoses, this can be really distressing for them. They can find it unhelpful. They can find it frustrating. Uh, I think that that makes sense. There can be some beliefs around different diagnoses as well, whether you're diagnosing multiple or you're trying to differentiate between them. Um, each diagnosis sometimes comes with stigma or stories that may not necessarily be true or reflective of the actual clinical experience. So, for us, keeping in mind what it might mean to actually have multiple diagnoses, does that make sense? Is that helpful? And within different diagnoses, what each of those would mean for a client. I talked about earlier the ACA withholding diagnoses. Um, that was more so refraining from actually diagnosing or putting on a record. But we also have clinicians who are not telling clients about their diagnoses. So they're actually making one, they're putting on the record, it's ending up in the notes, but they're not telling clients what their diagnoses are. And that, of course, can come from a concern about discussing it with the client. Maybe we don't feel confident. Maybe we're worried about how this will impact the client, how it'll come across to them. Um, Especially for diagnoses that have stigma or perceived worse prognosis. Uh, there are some we might be really hesitant to share with clients, and yet um, we need to reflect on that. Like, why? Are we worried about it being incorrect? What was our process like? Can we back up our process and the diagnosis that we came to? Worried about the distress that it might cause. Well, could there also be some relief from that diagnosis and an understanding of what they've been going through or what to do with that information? Um, Really being able to challenge this. And I don't think this is something that we can do on our own. Or that we would even necessarily need to do with the client in front of us, that we would want to talk to a supervisor or a colleague, get some consultation around the process that we went through, how confident we feel in that diagnosis, how to have that discussion with the client, and what to do if they are distressed by having this diagnosis. Um, they just note in the research that the client's concerns about stigma and prognosis are better to be addressed by person centered discussion. So, normalizing mental health, mental illness, and then discussing treatment options, management techniques, and essentially at the end of the day, supporting their recovery rather than avoiding it. That is the writer's recommendation there. And we also want to think about what information are we providing at the time that we're giving a diagnosis. And so I talk about this a little bit later as far as the thoughts a client may be having. So I'll go ahead and move on to those. But a client, if we're going through a diagnostic process, they may be sitting there going, like, okay, what is my diagnosis? I'd really like to find out. Um, yes, there are some diagnoses that have more stigma. Yes, there are some diagnoses that clients may reject. And yet, I think from what the researchers found is withholding a diagnosis, so not giving them a diagnosis but not telling them, actually makes clients feel isolated, confused, and significant. They tend to prefer that if there is a diagnosis that's been reached by the clinician, that the clinician shares that with them and explains how that diagnosis applies to their symptoms and what they described. Um, Even with diagnoses that clinicians may be more likely to withhold, or diagnoses that may be more likely to be rejected by clients, at the end of the day, it's found that more often than not, clients actually find it more helpful to have the information on the diagnosis than to not get it at all. Um, During the process, clients may not understand why the process is delayed. So explain that to them. I know when I went to a psychiatrist once, she had me fill out a questionnaire at the beginning, and then she had some mood tracking she wanted me to do. And then we came back and I did another questionnaire, and she was kind of explaining she wanted to see how things went over the course. I can't remember if it was weeks or months, but she wanted me to continue to track it. So even though she likely had some idea in mind that first session and maybe the second session, I continued to go back and she continued to reevaluate based on what I was sharing with her. So she explained that to me. That was really helpful. And I hope that we would do the same for our clients. The multiple diagnosis piece, I think it's important to add the why. So if clients don't understand why they have multiple diagnoses, then that can be really frustrating. It can be distressing, it can be unhelpful, especially if the diagnoses feel forced upon the client rather than agreed upon by the client and the clinician. And now we're back to the client wanting information from the clinician to make sense of the diagnosis. So make sure again that you're showing them how their life experiences map onto the diagnostic criteria. They will find that the most beneficial, but also help them to get access to useful information so that it's not being dismissive of their requests for information. This might mean leaflets, websites, support groups. So we can offer information, but also give them the opportunity to educate themselves further and come back with any questions or concerns that they might have. Somebody mentioned in the chat that they find it wild that mental health providers are not sharing the diagnosis or diagnosis process with clients. Feels like if you were diagnosed with a medical condition, but your doctor was afraid how you would react and doesn't share. Right. So we're thinking about any sort of like if you go and you're diagnosed with a cold or something. I know that's like doesn't make a whole lot of sense. It was the first thing that came to mind. Or you have the flu or something. Like the hope is your provider would tell you so you could figure out what do you need to take to treat the symptoms? What do you need to do to help yourself heal and maybe protect others, right? Um, we would hope that they would tell us that information just like we would hope that mental health providers would share with clients. But I think the unfortunate piece, just to back up your comment here, is that it is happening, and that is one of the things that the researchers did talk about, is that there are providers who are not sharing this information. Um, let's see. Somebody else had emailed, um, maybe navigating a previous misdiagnosis in light of a new diagnosis. So maybe let's see. Okay, so maybe separating a prior diagnosis that was misdiagnosed with a new diagnosis or maybe a more correct diagnosis. I think that often, and if I don't get your question quite right, feel free to reply, via email or send it in the chat. I think being able to pull apart the diagnostic criteria and show them where here's the prior diagnosis, here's the criteria for that diagnosis, here is the current diagnosis, and here's how it better fits into this new diagnosis. So, showing them some of the gaps, some of the areas where it doesn't quite make sense. And you're trying to separate it and show where, okay, yeah, maybe it used to be diagnosis A, but actually the symptoms that we're following under that fall better under diagnosis B, which is the new diagnosis. Just being more thorough and showing them how the new diagnosis better and more accurately reflects their experiences. And clients appreciate that. I will do that in my comprehensive assessments. If, let's say, there are certain symptoms showing up in one section, and it's like, you can see where they you check the boxes here, but actually they fit better over in this other diagnosis because they fit better within that criteria. That is the case with many of the mental health diagnoses we have, that the criteria can fit in multiple places. If you start to really break it apart, it makes sense that it falls in multiple places. But what's going to be most helpful is finding the one diagnosis, or if there's multiple diagnoses, where it fits the best. This is not a perfect science, unfortunately. We're not 100% advanced. We're not totally advanced in a way that we could do blood work or scans for everyone and be able to differentiate which diagnoses they have totally accurately all of the time. So we are relying on our diagnostic manual and the resources we have regarding the diagnostic criteria, and doing our best to fit them under those different umbrellas or categories. Um, that is a drawback, I think, of any diagnostic process. So that's why it would be really important to show, here's your prior diagnosis. Here's why it makes sense that some of these symptoms fit there. But once you look at the full picture, it makes more sense that they're falling under this diagnosis B, whichever the new diagnosis is. So I hope I answered your question. If that did not answer it, feel free to reply and let me know, or send me another email. I'll share some stage two takeaways here. If the person already has a diagnosis, what we're just talking about, explain your reasons for thinking together about an alternative diagnosis. So I could have just kept reading instead of talking on and on about my way of doing things. So if they already have a diagnosis, think about, or talk to them about how you're thinking about alternative diagnoses. Be really sensitive to any potential distress that they might feel or exhibit regarding any particular diagnosis. You're not going to be able to predict that all of the time, but just holding space for that, knowing that there is the potential for that, I think is really important. And then responding to that in the moment. For So, in addition to mental health providers, I think especially this is with like ongoing services where the clients are not being told what their diagnoses are. I've similarly heard for providers who do assessments. So, this is more like on a limited time, where really the purpose is to figure out what's going on, what diagnoses fit, what supports and next steps would be best. That the clients are receiving the report, but never going over it with the clinician themselves. So I like to have that space where I can share my report and we can go over it together. I literally share it on the screen, go through it line by line with them, ask, what questions do you have? Where did I get things wrong? Giving them an opportunity to collaborate on what I've written up based on what they've told me and any of the inventories and things that I've taken. But there are instances where clients receive diagnoses from an assessment, they're given the paperwork and never given an opportunity to discuss it with the actual provider. So, just making sure that we are giving time for them to understand what the diagnosis is, make time for questions for that, invite them to challenge or disagree with a suggested diagnosis. We're trying to figure out, like, does this resonate with their lived experience? Ask their perspective on suggested diagnosis and what impact this may have on their sense of identity. Similarly, be prepared to answer questions related to the diagnosis, how you came to that, the prognosis, and any limitations of the diagnosis. When you're referencing all of this information. And that's why you having a thorough diagnostic process, it's going to help you to better explain to anyone, whether it's a client, your board, your insurance company that you're paneled with, whatever. The more thorough your diagnostic process is, the better documented it is, the better you can back up what you're saying. You can answer questions, you can discuss more, but especially with clients. If you're feeling like withholding a diagnosis, so not just like not noting it on a record, but giving a diagnosis and not telling a client, be sure to challenge your reasoning for this. Um, if you can, I think most of us hopefully can, consider not formalizing the diagnosis, so not putting it as a formal diagnosis in any of your documentation until you can discuss it with the client. Challenge yourself, but also get support from others, supervisors, consultants, colleagues, whatever that looks like. If you're feeling any of those urges to not tell the client this information, get support from others in questioning why that is and how you can better take the next steps. And of course, explain that symptoms and diagnoses can change over time, especially for diagnoses that have that kind of severity level. I always point out to clients, you can see right there in the DSM, it says current severity. What is the current severity at this time? It is right now moderate, but in the future it could be mild or severe. Maybe in the past it was severe and now it's mild. Whatever it is, let them know that these can change over time. Okay. I don't see any more questions, so I'll keep going on to stage three, where we are applying and using the diagnosis. For a clinician, some of the things to take into consideration, just an application to understanding of mental health and mental illness. This really is, the diagnostic process is broader than just categorizing symptoms. Really want to make sure that you're looking at what is your diagnostic reasoning and how is this matching up to the social, the psychological, the biological factors that the client is coming to you with. That's going to help you in being able to explain your process and explain the diagnosis. Make sure that and we've already talked about this, but really make sure that your diagnostic process has a shared language that reflects any explanation that you have. So don't just use big terms. Some of I feel like, I don't know if y'all had this, but I feel like in my program, there was an emphasis on using the like professional terms for things. And I always felt really like not great about that, just because we don't always have a shared language around what those terms mean. To me, it always felt better to put it in simple, easy to understand terms. And I think that that makes your diagnostic process, your documentation more accessible as well for a greater number of people. It's not just about writing it so that this professional person who reads it next can just understand it. This is about the number of different people who may be reading it, but most importantly, the client. And think about how you're going to apply this to the client's care and treatment. So, if we're not seeing clients as being able to actively contribute to the process, we as clinicians can come across as really paternalistic. It can be associated with diminishing the autonomy of clients in their decisions about care and treatment. And I know that all of our codes of ethics talk about that, that the autonomy of clients is very, very important, if not at the forefront. How can they have autonomy if they don't know the diagnostic process we've gone through or the diagnosis that we've come to? That takes away their power and autonomy. A collaborative diagnostic process that involves a discussion around how the diagnosis can relate to decisions about care and treatment helps to foster agency and control for the client. They now have better information and being able to decide what next steps they want to take. Some of the thoughts that the client may have. Um, A diagnosis can be really helpful for them to understand their mental health and their mental health experience. So is different, and it's, I think, can be important for us to differentiate between naming the problem and labeling the person. I hear the labeling language used a lot related to mental health. This can be by clients themselves. It can be just in our general discourse, talk about using too big of words, just how we talk about mental health and even things that aren't related to mental health. And we use mental health or mental illness terminology. Um, so, how can we help with clients also? So, we differentiate it ourselves, but also help them to differentiate, that it is about naming the experience, and that creates that shared framework versus labeling them, which can be associated with stigma. Feelings of powerlessness have been associated with a diagnostic process that really keeps clients from developing their own interpretations of their distress and does not take into account a holistic biopsychosocial approach. Um, we want the diagnosis and our explanations to be valid and meaningful to clients because this is resonating with their lived experience. This can help with their identity. It can be more positive for them and help with them understanding what's going on. A client may also say they want to be involved in applying the diagnosis to care and treatment decisions. So, having that knowledge, that power is helpful to them only if they can understand it and apply it to decisions around their care, treatment, and recovery. It's not helpful to just say, like, hey, you have diagnosis B, good luck. We want to talk about how diagnosis B impacts their care, impacts their treatment, our recommendations for next steps. And if we're working with them long term, what we're doing, how we're incorporating theory or approaches and things along those lines. This can also help clients with insight into managing their mental health in ways that feel successful for them. And I've especially seen this in support groups where there's a shared language around their mental health experience. So, just as an example, a support group for folks with anxiety can be really helpful for everyone to come together and say, like, this has been helpful for my anxiety, or this has not been helpful for my anxiety. And then they get to make those decisions based on what they're hearing as well as sharing what they've experienced. So, beyond supporting decision making, clients have reported that they find diagnosis beneficial when it facilitates access to treatment, care, and support. So, what's the point of having a diagnosis? That kind of brings us all the way back to the beginning, right? What's the point of having the diagnosis? If it is to access treatment, care, and support, and clients understand that link, it's going to be that more impactful for them. So, what are some of the takeaways from stage three? Work with the client to figure out if it feels like this diagnosis helps them make sense of their mental health. Uh, Work with them to figure out how they relate to their diagnosis, how that relates to their history, their symptoms, and their lived experience, which comes back to the question that I got around, like, what happens if you're saying that diagnosis A doesn't apply anymore and now it's diagnosis B that makes more sense. That can help the client understand their history, their symptoms, their lived experience. Think with the client about how it may inform decisions regarding treatment. Make sure that they are involved in these decisions. So, if you are not actively making those decisions or making those decisions with them, are you involved in coordinating with someone who is? Discuss whether the diagnosis fits into their wider recovery story or journey. This can be really helpful to figure out. I think for many people, they'll say, like, okay, I was diagnosed at this year or this age, and people can really remember that. They might remember having symptoms prior to that, but when they're talking to me about their recovery journey, they can really pinpoint when they were first diagnosed. That's how impactful that is. So they may not realize it at the time of diagnosis, but you could start to have that discussion with them. Discuss whether the client has beliefs about the diagnosis that could either support or undermine their hope and recovery. Find out what misconceptions they might have, what additional information you can give. Make follow up appointments. So, if this is with an assessment, then consider another follow up appointment to kind of wrap things up around any further questions that they have. If this is ongoing treatment, make sure you're setting aside time to have questions and answers around the diagnosis and the diagnostic journey. Consider whether you need to involve others if they have a team supporting their mental health as they are taking on the information from the diagnosis and the journey on the diagnosis. So, some other key takeaways, I think, at the end of the day, how to make the diagnostic process collaborative. Make sure that at each stage, you're asking yourself whether the diagnostic process is person centered, shared, and equitable. Person centered meaning that we are explicitly aware of and attending to the needs of the client. Shared meaning that it is truly collaborative and values the experience and expertise of both the clinician and the client. And equitable, that we're aware of issues related to the power imbalance that is there and cannot be removed, and that we work to overcome them as much as possible, or at the very least, address them and try to make the relationship mutual and reciprocal. Okay. So that was the three-step process and breaking it all down, how to make it collaborative. How do you document all this? How do you reflect your ethical reasoning, your clinical judgment? How do you justify your diagnostic conclusions? And I know that diagnosis can be documented in a variety of ways. If it's a formal assessment with no additional treatment, if it is an assessment as a part of ongoing treatment, maybe at the beginning and further down the road, if it's emergent care, some of those emergency situations, and based upon your setting. So if you're in a school, especially like K through 12 is going to be very different than like an undergraduate level, like college, university, community mental health, private practice, primary care, or community teams, as well as being based upon the services and specifically who's paying for the services. Is it private pay? So the client is paying without using insurance. Are insurance benefits being used? Maybe grants are paying for the services. In the case of school, maybe student fees are paying for the services, or maybe there are some legal reasons that the assessment's being done, like a custody dispute, for example. So figure out for you which of these settings and which of the different payers of services apply to you and what's going to make the most sense with documentation, because you may have some requirements based upon that. For example, insurance may require that you track certain things within your diagnostic process. They may have very specific things that they want to see. Whereas when I worked at a student center for mental health on a university campus, we did not do any diagnosing. So there wasn't a diagnosis required for services because it was being paid for by student fees. Similarly, when I worked in a community center that was paid for by grants, we also did not do any diagnosing. Some and many community mental health offices do diagnose and are required to diagnose if they're using any sort of insurance benefits. But again, depending upon who's paying for it, you may or may not need that. So think through all of that, work with others who are in that environment as well to figure out what makes the most sense for you and the clients that you serve. And you can create different types of documentation based upon who's paying for the services. For example, if you're in a clinic where some of them are private pay, some of them are with insurance. Maybe you have assessments that are paid for by grants or something. Whatever makes sense for you and the documentation that you need, you can quite often create your own, whether it's like a Word doc or if it's in your electronic healthcare record. There are some planners that you can find, and I think one of the best known, at least for me anyway, the one that I knew was the Wiley Treatment Planner. It includes a checklist of symptoms for each diagnosis. So it is around treatment planning and figuring out like what sort of treatment plan are you going to have, what steps are you going to take, what theoretical orientation is going to connect to, but it starts with a checklist of symptoms. So that could be a really good place to start if you've never created your own checklist before. Though you can create your own diagnostic process simply using the DSM. Pull up the different criteria, have them as check boxes, include additional information so that you can have all of that. Like, this is the symptom that they endorsed, and this is how they describe that. That's helpful for you, it's helpful for your client, and it's potentially helpful for any payers who may read that. I will put in the resources that I put after all of these. So if you've ever come back and looked at the resources, I will put in there some links to different treatment planners and options, as well as some of the documentation supports that I found. So I'll just run through some of these. I'm not endorsing any of these, just letting you know they're out there, that there are comprehensive clinical assessment templates that you can use, that you can make your own. James Morrison has Diagnosis Made Easier and DSM-5 Text Revision Made Easy. Two different books there. The Documentation Wizard has a diagnostic assessment tool. Navigating the Insurance Maze has blog posts about diagnosis specifically with insurance. Makes sense. That's what they're focused on. There are the APA who puts out the DSM. They have assessment measures. They have an app actually with the diagnostic criteria, if that's helpful for you, a mobile app. They have a pocket guide and a desk reference. So I'll put all of those and a couple of other links to other resources in the resources after I do all this and update everything. With documentation, just make sure that you document everything that you can. In other documentation trainings, I talk about a limit to the level of detail. What I'm really thinking about here with diagnostic processes, if you're using a structured interview, questionnaires, inventories, make sure that you document that you use those and what the results were. If you get supervision or consultation, make sure that you're documenting that conversation. Who did you meet with? When did you meet with them? And what was the discussion, as well as what decision did you make after that? If you discuss the diagnostic process and the diagnosis with the client, make sure that you document that discussion and any reaction or questions that they have. If there's an ethical dilemma, which I've kind of touched on today, make sure that you document the steps that you take to resolve it. And there are notes specifically for ethical decision making. I can provide a link to those in the resources. You don't have to create much of this, you do not have to create from scratch. There are examples. If you're meeting with someone over time and tracking things, make sure that you are documenting that as well. So I'm thinking about the psychiatrist I met. They probably documented those mood tracking sheets that I turned into her. Um, One of the other ones that often comes up as kind of an easy diagnosis or a starter diagnosis is adjustment disorder. And I know that some insurance companies might be pushing back on that because it's used an awful lot. one of the reasons, and I'm not saying this is right or wrong, one of the reasons is in the diagnostic criteria, it notes that there's a limit to when that diagnosis and those symptoms would remain. So the literal language is once the stressor or its consequences has terminated, the symptoms do not persist for more than an additional 6 months. You can specify if it's acute, if the disturbance lasts less than 6 months, chronic, if the disturbance lasts for 6 months or longer. Essentially, what it's saying is it needs to be continually reevaluated and documented. Is the stressor still ongoing? Are the consequences still ongoing? Are the symptoms still persisting? So, this comes back to our diagnostic process. It's usually not good enough for like a one and done kind of thing. All right, we did the one assessment. Here's your diagnosis. Off you go. We'll never explore this again. Whether you made the diagnosis or someone else did, it's always good to track it over time and document how you're tracking it. Okay. I realize we've almost come up on an hour and a half. So if you have questions, concerns, I know most of you have probably left. Feel free to put those in. If you're watching this later, put that in the chat or email it to me. The last thing that I will just comment on is some of the requirements, the newer requirements that we have around giving clients access to their notes and our documentation. And often this is talked about in the realm of digital access, so access through the EHR. And that might be directly to our notes as they are written or to a summary of the notes. And if you've ever gone to a major medical institution, like a hospital, for example, and many of the doctors that I go to that are part of the larger like hospital systems, they will provide you as you walk out the door with some notes, basically a summary of who you are, why you came today, your vital signs, any diagnosis that was made, treatment plans for next step. So just keep in mind that as we are our responsibility for providing that to clients increases, then our justification of the process and our ability to communicate that with clients needs to improve as well. There was a study done on healthcare professionals specifically related to mental health that as they were required to provide clients with digital access to their documentation, that the professionals generally tried to create more client friendly notes. So think also back to like the medical jargon was being replaced with easier to understand language. So that's the last thing that I'll note. I'll include that in the resources as well for today because I think that was a pretty interesting article to read if you get a chance. If you have questions, comments, concerns, put them in the chat, send me an email, let me know what you thought. I look forward to joining you all next month. I'll let you know when the next live will be. And I hope you all have a wonderful rest of your year. Thanks, y'all.